Great. Thanks, Mark, so much. I really appreciate it. And I just enjoy talking about enlarged prostates and prostate problems. You know, I've been in practice here since 1991 in the same practice, so it's been over 30 years. And over time, I've found that I gravitated more towards obstructing prostate glands. I enjoy the challenge of trying to treat that. But I think also there's the fun of it has been the fact that there's been so many new developments in this. When I was first a resident back in the late 80s and early 90s, we really only had two things. It was observation and then having a TURP, or what we call a transurethral resection of the prostate. And it wasn't much to offer people, and people had to wait until they were in dire circumstances before they had any intervention. And then little by little, we started having medications and better medications. But it wasn't until really the last 10 or 12 years that we've been able to offer things that are improvement of the medications with less side effects. So let's go ahead and get right into it. And if I get too excited about this, please forgive me, because like I said, I really enjoy this part of my practice. And I've actually narrowed down my practice to more of this than anything else. When we talk about the prostate, we really need to know where it's located and what it does and those types of things, because most of us really don't know where it is. And essentially, it's a walnut-sized gland. Well, it's a walnut-sized gland to start with, but it is immediately under the bladder. What I really like to give as an analogy is a funnel and a donut. If one can visualize a funnel and then a donut, put it onto it. Obviously, the funnel is the bladder and the urethra, and the donut is the prostate. And the donut or prostate does surround the urethra. And as time goes on, in fact, starting from our 20s, our prostate starts to grow, and it continues to grow. Believe it or not, unfortunately, especially for me, there's three things that continue to grow in a man's life: nose, ears, and prostate. And I've already got the nose and ears problems, and unfortunately I got the trifecta, because I do have an enlarged prostate, and I suffer from many of the symptoms that you all suffer from. What's the purpose of it? Well, the prostate makes a fluid that helps transport sperm during ejaculation. In fact, a very little known fact is that the prostate and seminal vesicles, these are the glands you can see behind the prostate, contribute about 95 to 97% of the fluid that a man ejaculates. Only 3% is actually sperm. So this fluid helps. It's the milieu that the sperm are in that keep the sperm in a right frame of content. It keeps them alive and allows the sperm to live until it obviously gets up into the cervix and up in the uterus for fertilization. Now, the prostate starts at a normal size, and in the early to mid-20s, it starts to grow. And as I said before, it continues to grow throughout the rest of a man's life. Now, when we talk about the prostate, there's many things that we can talk about. We can talk about the fertility aspect. You can talk about the possibility of prostate cancer, prostate infection. But we're going to have to limit our discussion tonight to the enlarged prostate and benign prostatic hyperplasia. So let's just go for a little overview as we've been talking. BPH means benign prostatic hyperplasia. Benign meaning it's non-cancerous. No matter how big the prostate grows, it's never going to spread and go to other organs. That would be a cancerous condition. Again, it's prostatic, of course, because we're relating to the prostate, and it's hyperplasia. We get more cells, and the cells are larger. So this is a benign but definite enlargement of the cells and the number of cells that are going on. The normal size when we start is probably about a walnut, and this can lead to prostates that I've seen as big as a small, like a tennis ball size. I mean, it can get that big. Now, what can the problem for this go? It can be variable. There are many men still to this day, even in their 70s to 80s, that don't have much enlargement, or if they have enlargement, it doesn't cause any problems. But for most of us men, as the prostate gets enlarged, it causes obstruction to the flow of urine. Essentially, that donut that we were talking about earlier, not only does the donut expand outwards, but the donut hole gets impinged upon, and that donut hole becomes smaller, and there is obstruction to the flow of urine out through the bladder and the urethra. Now, again, this is not prostate cancer. You can have a gland the size of a tennis ball and not be cancerous. Enlargement of the prostate doesn't cause prostate cancer. Now, the symptoms can be similar. However, I will say this, one of my pet peeves when I read articles about prostate cancer in the newspapers, articles are some of the symptoms of prostate cancer are slow flow, trouble getting it started, starting and stopping, or back pain, Well, that's silly because almost always those symptoms that mentioned above are from a benign enlargement of the prostate. And if you have back pain from prostate cancer, that means it's metastasized to the lower back. And that's a terrible symptom. The signs and symptoms of prostate cancer are none. We should eliminate the signs and symptoms for diagnosing prostate cancer, because we should be diagnosing prostate cancer when there are no symptoms or minimal symptoms or even overlap of symptoms for an enlarged prostate. So, but enlargement of the prostate doesn't mean that it's prostate cancer. Now, you could have enlargement of the prostate with prostate cancer, but if you want to find out if you have prostate cancer, we use PSA levels, we use rectal exam, and there's MRIs now of the prostate and special blood and urine tests. But again, we're not going to talk too much about that, maybe another night. Okay, so as the prostate enlarges, as I said before, it impinges on the urethra, and it can stop the flow of urine and cause many, many symptoms that we'll get to in just a second. However, I would like to say that just based on the size of the prostate, you cannot tell a man if he's going to have issues or problems. I have seen guys with that tennis ball prostate, and they have zero symptoms, and it's incredible. Whereas you have guys with prostates that are just a little larger in the walnut size, and they have terrible symptoms. So size alone does not necessarily correlate with the problems you're going to have. Now, what are the symptoms? I think we all know that, but we like to divide those into obstructive symptoms and irritative symptoms. Obstructive symptoms are what you would think it would be: slow stream, trouble getting it started, starting and stopping, dribbling at the end. One of my favorite questions is, how do you think your flow comes out now compared to your 30s or 20s and 30s? And most men will definitely say, oh, it's a lot weaker. Irritative symptoms would be the sudden urge to urinate. When we have to go, you've got to go. Going more frequently, more frequently in the day and at night. Now, who suffers from BPH? Oh my gosh, so many men suffer from enlarged prostate. Most men too don't want to live with their symptoms. 95% of men with these type of symptoms don't want to live with them. 50% of them say that it interferes with their daily aspect of lives. And this brings up a really important point. When we're treating BPH or enlarged prostate, there are absolute indications to treat and there are relative indications. The absolute treatments are if you can't urinate at all and you need a catheter, if you're forming bladder stones, if you're not urinating well enough that the pressure is breaking up in your kidneys and causing their obstruction of your kidneys, and you're not draining your kidneys, and that can lead to kidney failure. Blood in the urine that can't be controlled. These are all symptoms that say you have to have treatment. But the great majority of people don't have those symptoms. The great majority of people are just bothered by this. And why we want to treat BPH or enlarged prostate is for quality of life. We're not trying to treat this to save the world from hunger. We're doing this for your quality of life. Some men, they get up 3-4 times a night and they say, I'm really not bothered by it. Other men get up once and they're bothered by it. So everybody's affected by this differently. But our goal is to affect the quality of life and improve that. So 50% of men over age 50 have trouble with urination from this, 90% of men by age 85. It doesn't mean everybody, but most men. So we know that there's millions and millions of men in there in this world that are in this country that are affected and bothered by urination. Are the things that lead to this? Yes, obesity does seem to have affect this more and have a progression of BPH. Lack of exercise could increase it. Family history. My dad had a huge prostate and he had to have an operation and did very well with that. But I do think that there is a genetic factor. It's not like brown eyes and blue eyes, that type of a thing. But I tend to find that men who have trouble with urination usually have relatives that have trouble as well. Now, how do we evaluate that? There's a lot of things we like to do. Number one is history and physical. I'd like to hear about what symptoms you have. How bad are your symptoms? And that's very important. And you can see on the right side of the slide, there are indexes that kind of tell us and quantify how bad the symptoms are. There's an AUA index. There's an International Prostate Symptom Score. There's a quality of life questionnaire that we use. And we can add these. And this kind of quantifies how bad or bothersome your urination is. And these are important because we get a number and a quantified number of this. And that way, when we intervene with any kind of treatment, what happens is we can see if you've made a statistical improvement in this. Now, that's the history part of it. We also like to do a physical exam. Most of the time, we do a digital rectal exam. We tend to get a PSA just to make sure that we're not worried about prostate cancer. There's also a couple of easy tests that we do. Number one, we have what's called a uroflow. This is where a man will urinate into a funnel, and this funnel with a machine determines how fast a urine sample comes out. How fast does a man urinate? Does he flow at 6 cc's per second, which would be very slow, or does he go at 24 cc's, which would be actually a fairly good flow pattern? That kind of gives us an idea of how fast or slow your urine stream is coming out. Another very important test is what's called a post-void urine volume test. What that means is we have the patient urinate, and then we scan their bladder. This is very non-painful, and we see how well the patient's emptying his bladder. Does he leave behind a half an ounce, or does he leave behind 12 to 15 ounces? And that's very important, because if a man's not emptying his bladder well, we know there's a decompensation pattern going on, because when we're in our 20s, we empty completely. We empty our bladder completely. So if we're not emptying 6, 10, 12, 15 ounces, we know that there's a problem, a more serious problem going on. All right, let's get to treatment options. I think that's really important. I like to divide this into 3 levels of treatment. Level 1 would be either behavioral modification, observation, or perhaps medical therapy. Second line therapy would probably be something to the effect of doing a minimally invasive procedure. We call these MIST, M-I-S-T procedures. And then the third level would be going to the operating room. And we're going to cover all of these things. The more invasive the treatments, by the way, probably the more successful, but also the more side effects and the more involvement and more risk that you get on. So let's talk a little bit about some of these options. By the way, I know that a lot of people aren't going to like to hear this, but this has been researched fairly well, and there are no dietary supplements, phytotherapeutic agents, over-the-counter things that really improve urinary symptoms. I know there's a lot of people out there that say, oh, I take saw palmetto, or I take Pygium africanus, all these things, and they might help. But when thorough testing's done, there has been no therapy that is really shown to be very effective. So let me touch upon that just a moment. One of the problems with testing these kind of supplements is that in the past, when we've done studies on drugs, drug studies, a third of the patient gets better on placebo. So anytime we do a study on Flomax or Rapaflo or any of those alfuzacin, any of those studies, we have to have a control arm where we give them a sugar pill. A third of the patients get a sugar pill, and 2/3 of the patient get the actual drug. And of the patients that just get a sugar pill, a third of the patients improve. And so there's a very high combination of psychological involvement in this, along with physiological involvement. But suffice to say that there has been no real improvement with any of these supplements. Now, what's watchful waiting? That means doing nothing. But you could be lifestyle modification. Some men who say they have urgency of urination. Well, if they go to the bathroom every hour, hour and a half, or maybe every 2 hours before their bladder tells them they can go, they have a much less of urgency because they're emptying their bladder before their bladder tells them to do that. Fluid modification can be helpful too. If we reduce our fluid intake, especially in the 3 hours or 4 hours before bedtime, we're probably going to get up less at night. So those are some of the things that we can do. The wonderful thing about this is that there's no treatment that has to be done. And so if there's no treatment, there's no side effects. And some people can actually get improvement with this. And I'll tell you, I can't tell you how many times I've helped people with getting up at night, going too often, by just reducing their fluids. Remember years ago when they told us, how much should we drink in fluid? They said 8 glasses of water a day. Well, what they should have told us was drink the equivalent of 8 glasses of water a day. So 8 times 8 is 64 ounces. Our bodies don't need more than 60 or 65 ounces of total fluids. And that includes your water, your milk, coffee, soda, beer, wine, whatever. All fluid, 64 ounces intake is more than enough hydration for us. I've had patients do voiding diaries where they show them they put out 100, 120 ounces of fluid. And of course, they're going too often during the day and the night. So that's the type of thing I think we first should look at, because we don't need that excess of fluid. Remember, our bodies are finely tuned machines. What would happen if we took all that fluid and we didn't have to get rid of it? We'd swell up. We'd look like a puffy man, like the Michelin man. So you have to understand your body is a finely tuned machine and it wants to not swell. So any of that excess fluid you get has to come out in urine. Another way to go is with alpha blockers. This is probably the most common way that people are initially treated. These are medications that actually relax the muscle fibers in the prostate and allow the urine to flow more freely through the prostate and through the bladder, from the bladder through the prostate gland. So these relax the muscles and they can work very, very well. These are the Flomax, tamsulosin, alfuzosin, uroxetrol, Rapaflo, Silodosin. Those are those kind of medications. Can work extremely well in people. However, A, they don't always work, and B, there can be significant side effects. Low blood pressure. Unfortunately, the same muscle fibers that are in the prostate are the same fibers that are in our blood vessels. So if you relax the muscle fibers in the prostate, you may relax the muscle fibers in the blood vessels, and that could drop your blood pressure. Every time a new one of these medicines come out, there's less effect on the blood pressure and more effect on the prostate. However, there always can be that effect. When you're on Flomax, and a lot of men will complain of dizziness when they go to stand. It can drop your blood pressure. Fatigue is another one. Nasal congestion. There's little muscle fibers in our nose area, in our sinuses. And so when those muscle fibers are relaxed, you can get more dripping, more sinus problems, that type of a thing. So these are all the things that can happen. Many men do stop taking their medication. As the slide says, about 70% of men will stop taking these medications within a year. Benefits: no general anesthesia, no surgical treatment. You know what the potential side effects are, but again, they may or may not give you help, and there can be the potential for side effects. Alpha reductase inhibitors. These are medicines that actually stop the growth of the prostate and can shrink the prostate. They lower the production of this hormone called dihydrotestosterone. Testosterone is in all of our male bodies, and when it gets into our cells, it converts from testosterone to 5-dihydrotestosterone. And it's this 5-dihydrotestosterone that actually causes the prostate cells to enlarge. So this prevents the conversion from testosterone to 5-dihydrotestosterone. What a great thing to do to actually shrink the prostate. Well, there are some issues with this. About 10% or more of the men who take this have sexual side effects, whether that be lack of ejaculation fluid, erectile dysfunction, lowered sexual drive, breast enlargement, soreness, or tenderness. So these are side effects. Now, these are all reversible. So if you take this medication and you get any of those, we stop the medicine and it can reverse those side effects. Who does it work on? Usually guys who have large prostates. Now, prostate size can range anywhere from 20 or 30 all the way up to 300. It's not going to help the guy who has a prostate that's 30, 40, or 50 cc's usually. It's usually these larger prostates where it's going to help. And that's something that we determine by rectal exam, maybe by prostate ultrasound. So it can be helpful. The other drawback is that it takes about 6 to 12 months for this to really work. Now, we've had this and we'll have this for years and years to come. So it's not a horrible thing to start and see if it works, but you really got to give it 6 and probably 12 months to see whether or not this will be beneficial. Okay, now we're going to talk about what I think is the second level of treatment, and that is a procedure that I can do usually in the office. Now, these procedures don't have to be done in the office, but they sure are nice that you could do them here and not have to go to the operating room and be put under general anesthesia. The first one I want to talk about is Rezum. Now, what is Rezum? This is an outpatient therapy that I do in my office. Now, we do use some anesthesia. It's called nitrous oxide or laughing gas. You may have heard about having that done in the dentist's office, but we do that right here in the office. And the wonderful thing about nitrous oxide is it totally wears off in 5 minutes. So a patient can actually drive themselves in, have this procedure done, sit around for 5 minutes, and it's totally out of their system. They can drive home. So it's really, really wonderful. Now, what is Rezum? It's an outpatient therapy that uses natural energy stored in water vapor to shrink the prostate gland. So what do we do with this? We have you come into the office, you breathe the nitrous oxide, I go through the penis with the scope, and I actually inject this water vapor or steam into the prostate. Little 9-second treatments, 9 seconds here, there. And it can be anywhere from 4 to 6 treatments all the way up to a maximum of 15, depending on the size and the shape of the prostate. After that procedure, because we inject the steam, it does kill prostate tissue. The prostate doesn't like that, and it swells. And because the prostate swells, the donut swells outward, but also inward, we usually need to put a catheter in for 3 to 5 days after the procedure so that the urine will drain well. Now, what are the potential side effects? Definitely the first couple of weeks afterwards, you can have painful or frequent urination. There can be blood in the urine, which is not dangerous at all. You can have blood in the semen, which again is not a problem. It's rare to have urinary tract infections. It's rare that a person won't be able to urinate after the catheter comes out, but there are can be a few weeks of irritated and obstructive urinary symptoms, which is expected, but it has a really good efficacy rate. I think somewhere between 80 to 90% of my patients are getting improvement from this procedure. And the wonderful thing about this now is that I've been doing it for 5, 6, 7 years, and I'm seeing those patients back at 5 years, and they're still doing well with very minimal regression of their symptoms. And that's really gratifying to me to see these patients doing so well. How long could you expect this would work? Well, we don't know for sure because we haven't done those 10-year studies. That really hasn't been out for 10 years. But we know at 5 years, if you're doing well in the beginning, most patients, the great majority of patients are still doing well at 5 years. So the benefits, again, it can be done in the office, although if someone doesn't want it in the office, we'll do it under general anesthesia. That's fine. There's no implant. And the surgical treatment rate's only about 4.5% at the 5-year mark. So like I say, I think it has a very good success rate. You just have to put up with some of the initial difficulties in the first few weeks. What actually happens here, you can see the before picture where you have the hyperplastic tissue there, and then afterwards that hyperplastic tissue that we put the steam into will die. The body reabsorbs that dead tissue, and then your prostate has an open channel. You can urinate better. And here's a nice little video about this. I think this is a nice video. Hold, please. All right. I have to click this. Give me just a second. Oh, there we go. And I'll shut up while this video goes on.
I found out that I had BPH. My symptoms were a slow stream, and I would wake up frequently in the middle of the night. I first heard of Rezum when I was researching enlarged prostate and the procedures to repair it, to fix it. And Rezum was one of them. The more I researched Rezum, it was the latest and greatest technology, and I want to be part of new technology. I think technology is good. My experience with the Rezum procedure was very good. After the procedure, I was a little worn, a little tired, and the next day I felt fairly good and was able to get up and get around.
Since Joe's Rezum procedure, we're able to spend much more quality time together, fewer interruptions, and we're just happier as a couple. The Rezum treatment has made a very big difference in our life.
So I want to have a little disclaimer there. Will not help your golf game. In fact, I don't think he has a very good golf game. That's just a joke. Okay, so 97% of patients would recommend Rezum to another person. I don't know. Let's see here. All righty. Now, I'm going that way. Okay, let's go back over some. Oh boy, hold please. You got the worst guy. Here we go. Now I'm on. Okay, now let's talk about another minimally invasive treatment, which also can be done in the office. What is this procedure? It's called UroLift, and it is also a procedure I can do in the office. And what we do is go up through the penis with the scope, and we put little clips in, or what we call anchors. There's actually a small little metal clip that goes on the inside of the donut. There's a small little clip on the outside of the donut, and there's a suture in between these two little clips. And that suture contracts and it pulls the prostate open and holds out enlarged prostate tissue so it no longer blocks the urethra. Again, it can be done in 5 to 6 minutes like the UroLift. Has many of the same side effects about that frequent and painful urination, blood in the urine, and some of these things. These side effects are usually a little less in length. They're usually 3 to 5 days, rather than the 2 to 3 weeks that can occur with the Rezum. And we're getting, good results with this. Is it as good as the Rezum? No, I don't think the effect of this is as strong or as long lasting. But I've had many patients do very well with this. One of the nice things about this is that most men don't need a catheter afterwards, whereas with the Rezum 3 to 5, usually had a catheter for 3 to 5 days. And the symptoms usually are almost totally resolved after 4 to 5 days. No general anesthesia. There are permanent implants. Some people are very concerned about the implants. I don't think it's a big deal. The implants are made of stainless steel and another material I'm blanking on, but it really is no problem. And the implants are very small. So the retreatment rate is definitely higher with this. And I will say that I've had a number of patients and do very well with this, but I've also had a couple of percentage, maybe 10% of the patients who did well to begin with, after 6 months to a year, have lost some of the improvement. So, still an excellent procedure. I don't think it has the success rate of Rezum, and I don't think it has the durability to Rezum, but I do think it has a much quicker recovery if that's important to the patient as well. Now we're going to go on to the third line of treatment, and this is stuff we can do, or surgeries we can do in the operating room. This is where we have to have general anesthesia. We go up through the penis with a scope, and in some way or fashion, we open up the tissue. We actually remove tissue, so you have a nice big channel that goes up there. Now, the benefit of any kind of procedure like this, and we're going to talk about all of them, or most of them, is that it actually opens up a channel and you do have greater results most of the time. It has about a 90 or 95% success rate, but along with that success rate comes general anesthesia and the risk of general anesthesia, as well as increasing risk. So let's talk about the individual different types of one. The first one's a green light laser therapy, and I'm going to be very upfront and honest with you. I'm not a big fan of this. In my experience, when you use a laser, you can open up the channel. Initially, it looks beautiful. It's like you're just evaporating the tissue, but after you get about a centimeter into the tissue, it doesn't seem to open up the channel very well. Now, my partner does it. Dr. Randall does it and loves it, does a great job. And if you're ever interested, and I can refer you to Dr. Randall, he does a wonderful job with this. In my hands, I just haven't seen this be as effective, not to mention the fact that it can be very irritative. When you're treating with a laser, you're actually burning tissue, and some of the tissue gets burned and evaporates away, but some of it gets partially burned, and that can lead to pain afterwards, discomfort, burning with urination, feeling like you have to go urgently and frequently for several weeks, if not months. So that just hasn't been, in my hands, something that I like to do. We can show you the green light here. Okay, now having said that, I don't use it, or I'm not a big fan of it. Dr. Randall does a great job, plus which there are some definite advantages of using the laser. I do want to hit upon those just because of the fact that there are people who love it and have had tremendously good results. One of the biggest thing is it's an outpatient procedure. You can go into the hospital, do the procedure, and go home the same day. You don't have to spend, and you don't have to wear a catheter more than a day or two afterwards, and it doesn't burn any bridges. So if this doesn't work, you can still have any of the other procedures that we do, the TURP and all the other things that can happen. So even though I don't use it a lot, Dr. Randall does and has great results with it. So don't eliminate this as a very viable option. Now, what about a transurethral resection of prostate? This is the procedure we've been doing for probably 60 years. And essentially, it is not an outpatient procedure. It's actually an inpatient. We do the procedure and we have you stay overnight, one day, and then go home with a catheter. What is it? We have an instrument. We have a scope where we look up there and there's a heated wire. And it's almost like just shaving off a slice. So we go in there and we look and we take a slice and a slice, and like almost like whittling away at the inside of that donut hole. It takes about an hour, hour and 15 minutes to do the procedure. It has an excellent result. I would say that it has a 90 or 95% efficacy rate. However, the more effective a procedure is, the more potential for possible complications. And what are those possible complications? Well, first of all, there's an extremely high chance, 80 to 90% chance of what we call retrograde ejaculation. That would mean that when a man has sex, instead of the fluid coming out through the penis, it goes back up into the bladder. Is that dangerous? No, not at all. And you just urinate it out the next time. But most men really feel that they've lost sexual pleasure with that. So that is about a 90% chance, 80 to 90% chance of that happening. So you should count on that happening. There's also about a 1 or 2% chance of urinary incontinence. That's leakage of urine. Now, that's a very low risk, but it certainly is a significant risk. If that were to happen, there are ways to fix it, but boy, we certainly would hope that's not going to happen. And there's also a percentage of losing erections. Now, that depends on how aggressive the resection is and what the level of erectile function is prior to the procedure, but it is about 5 to 10%. So that's something that has to be taken into consideration. Now, when that procedure is done, it's done in the hospital under general anesthesia. You spend the night in the hospital, you go home with the catheter, and we take the catheter out 2 to 3 days, probably 2 days later. But again, that is the gold standard that everything is compared to, over time. The surgical retreatment rate is only about 5 or 6% at 5 years. And again, there's blood loss with this. There's a chance of blood transfusion, which is low, but there are certainly more risk with this. And the more in-depth the procedure, the better success rate, but also the higher list of risk. Now, what's a prostatectomy? That means removing the prostate, but I want to say a little caveat here. There's different types of prostatectomies. If the person has prostate cancer, the whole prostate is removed, and that's a radical prostatectomy. Now, we do it with scopes now, and it's a very safe procedure now, but that means you remove the entire prostate because there's cancer there. What we're talking about is a simple prostatectomy. And the best analogy I can give you is of an orange. Think of the orange where you have an orange peel and the orange substance. When we do prostate procedures, we do not remove the entire prostate. We leave the orange peel behind. And when you have a prostatectomy where we take out most of the prostate, you take out the orange substance and leave the orange. Now, this is done when you have a very large prostate, prostates that are 100, 120, 150, 200 cc's. We're going through the penis when any of these procedures probably won't work or won't work well enough. And so this is where we put the scopes in there, the tubes in there, and through that we put a scope and do that procedure, and you take out the prostate. It actually comes out almost like a ball. And that's done with what we call laparoscopy. So we don't do that via an incision anymore. We make probably 4 little incisions where we put a tube down there. I've got 2 of my partners who do a fantastic job on this, but again, it's only for very, very big prostates. There are risks with this. It has an excellent success rate, probably 95% success rate, but there is a risk of some incontinence or leakage of urine, blood transfusion, things like that. But it tends to be very successful, but it's a pretty big procedure, not really indicated unless your prostate's one of those that is a very big size. There's also something called iTIN. This is a stent. Now, this is a procedure. I think we all know what when men or women have stents put in their arteries, they're little spring-like devices that keep the artery open. Well, there's actually a wonderful procedure that does the same thing for the prostate, but it's a temporary stent. We put this little implant in. It's a nitinol device that reshapes the anatomy of the prostate, probably puts so much pressure on the prostate that it decreases blood supply, and maybe some of the prostate would die and get reabsorbed by the body. And it's only put in for 5 5 days. So we can do this in the office as well with the nitrous oxide. We go up through the penis with a scope, we implant this, takes 2 to 3 minutes, and then a patient would wear this for 5 days. They come back to the office and we remove it. Potential side effects, the same things: pain and burning with urination, blood in the urine, urgent feeling. And this is something that would last usually while the implant's in that 5 days, and might last for another 3 to 5 days afterwards. So far, we're getting very good results with this. Again, an 8.6% retreatment rate at 3 years. We don't have 5 or 10-year data on this either. It's a little bit newer procedure. But the beautiful thing about this is there's no long-term risk with this. In fact, let's go back to the UroLift, where those little implants, the Rezum and the I-10. These 3 procedures have no long-term risk except with the Rezum. That's the steam procedure, where you can have that retrograde ejaculation that I mentioned in other procedures. And that varies on how aggressive I do the procedure. It can range anywhere from as low as 5 or 10% up to 60%, and depending on how aggressive I am with the procedure and how much the patient doesn't want to have that side effect. If they come in with an idea of like, I really don't want to lose my ejaculations, then I will do the procedure in a certain way where we really minimize that risk down to about 5 or 10%. Now, with the I-10 or the UroLift, there is no risk of retrograde ejaculation or incontinence or impotence. So these procedures really, and that's what's really got me excited about this, the fact that we're able to do these procedures with very little risk, but can really change a person's life in that way. Now, you probably all been starting to hear about aquablation. Aquablation is done in the operating room, and it's usually done for much larger prostates. Again, those prostates that are 80, 100, 120 cc's. And essentially what we do is bring you to the operating room, put you to sleep under general anesthesia. An ultrasound probe is put in the rectum that gives us a picture of the prostate. On the screen, I can tell this device where to start, where to stop, how deep, how not deep to go. And then we put a device in through the penis. It's a high-power water spray, and it correlates to that screen image. And we turn the machine on, and it's a high-power water jet that goes zzz and just blows open the prostate. Now, the beautiful thing about this is it's almost robotic, where the machine does the work for me, so it's not up to human error to make issues. But there are some problems to it. Once we do the high-power water spray, we still have to go in afterwards. We still have to go in there and do some of the rotor-rooter or the TURP procedure. And you still have to be in the hospital overnight. There tends to be a little more bleeding with this procedure than the old TURP that we talked about earlier. But still, it's a wonderful procedure for enlarged prostates and that type of thing. So it's like a TURP, only the first part of the procedure is done with a robot or machine, as we like to say. Transurethral needle ablation, I'm not going to spend a lot of time on. We don't do it anymore. Very few people do this. It didn't turn out to be as great as we thought. This is where you go up through the penis, and instead of injecting the steam like we do with the Rezum, it puts in a radio frequency wave, which we found out really doesn't work very well. And some of the data may have actually been faked when this first came out, unfortunately. So in summary, we know what the prostate is, why it works, what it does. We know that it grows. We know that this donut, quote unquote, grows outside, but the donut hole shrinks inside because of the growth. We know that there's a lot of things we can do to treat this. Again, there's watchful waiting, there's medications, there's procedures I can do in the office, and there's certainly procedures we can do in the operating room. So with that, I'd really like to open it up for questions that you might have on this procedure. I hope I was thorough, but if there's anything that didn't come across, please feel free to ask the questions.